Welcome to the Jaros Health Podcast, where we make it easy for you to better serve older adults. This is a weekly Jerry on Ice segment that is a collaboration with the Institute of Clinical Excellence, the official Con Ed provider for the Jaros community.
Hello, everybody. Christina Previtt here. I'm one of the two lead faculty for the Jerry PT division of the Institute of Clinical Excellence. I am pulling a classic Mike Eisenhart and Jeff Moore today as I am doing the car edition of PT on Ice. And that is because I am heading to an OB appointment right after this. So I'm just over 34, almost 35 weeks pregnant. And so now I feel like I have appointments all the time. And therefore, the only way for me to make sure that I made my appointment and still got on here was to get into the car and do a live version of the PT on Ice podcast. So it has been a really, really busy couple of months for the PT faculty through ICE. I'm really jealous of any of you who are about to descend on Vegas. The faculty is about to go for the sampler, which is super, super exciting. And I'm really sad that I'm missing it this year. If you're not on the Hump Day hustling, that's kind of where you'll get the updates on a lot of the courses and some of the new material that's coming out from a research perspective. And we're not super spammy. It's just like 5 different research articles each week that could talk about some of the new and emerging literature that's coming up in the field of Jerry, but also in all of the different divisions that ICE is going through. So today I thought that I would talk a little bit about the necessity, or if there is a necessity, for hip precautions post hip replacement. And so there's an interesting thing that happens in medicine, and for good reason, is when there's a certain recommendation that is made, usually the first reason why we make this recommendation is to be conservative, especially when we're trying out a new modality. So 2 examples that have kind of come and gone, but unfortunately some of the stigma around it have stayed, are kids in resistance training, right? Like there was a theory that seems to never want to die that if kids lift weights that they're going to affect their growth plates, and that has been debunked. There has been position statements, but still I'll get parents who ask me about that, saying that they've heard that it's bad for their kids. And so that was a recommendation that was made based on theory, and then research came in, showed that it wasn't true, and yet we're still kind of holding on to that conservative mindset with it. Another example is in breast cancer. So for individuals who had lymph node resection as a part of their cancer treatment, the previous thought was that you shouldn't lift more than 10 pounds ever, because it would increase your risk of lymphedema. That has also since been debunked. People have tested it and actually shown that individuals who take part in resistance training, because of the pumping action that happens through the upper body, that it can actually reduce rates of lymphedema. And the recommendation is now, if you're in an active flare, to avoid resistance training until that flare has come down. But still, I'm having moms or grandmas or women who have had breast cancer who are basically told not to lift their kid up ever again, or their grandkid up, because they're kind of having this restriction. And so when I started looking at some of the literature for hip replacements, I was wondering if this was going to go in the same type of trajectory. And so the justification for some of these hip precautions is that we're trying to avoid incidents of hip dislocation post hip replacement. And this makes sense, right? We're just disrupting a lot of that joint musculature. It's a weight-bearing joint. So we want to make sure that the soft tissue in the capsule around that joint has had enough time to heal in order for it to maintain or create a certain amount of stability in order for that joint not to dislocate. What we also know is that 3 of the biggest complications that are going to lead to revision for a hip replacement are a prosthesis loosening or dislodging, a full dislocation, and infection. And the loosening of the prosthesis is probably number 1 in terms of the complications that we're going to see, but dislocation is number 2. And so that is why these precautions have been in place. what is happening sometimes, so these precautions are supposed to be placed on the individual who's post hip replacement for 6 weeks. Unfortunately, just like sometimes in cardiac surgery, these precautions aren't DC'd. And because they're not DC'd by the surgeon, or they don't see the surgeon until 12 weeks, we're having an extended period of time where some of our clients are very fearful of different movements and are afraid that they're going to make their hip worse, and therefore aren't doing as extensive of a rehab process in the early stages as we would like them to, in order for them to have the biggest chance of success, biggest chance of return to activity, return to work, and even in some cases, return to sport. And so in 2015, there was actually a systematic review that was looking at rates of dislocations for individuals who prescribed to the hip restrictions and precautions, and those that didn't. Over the last 10 years, there has been a huge change in the surgical management of a hip replacement. We have realized that the size of the femoral head in the joint capsule, and therefore the size of the prosthesis, makes a big difference in rates of dislocations, and as well as the surgical approach being taken. So some of these precautions may have been necessary a little bit earlier in the hip replacement world, but as surgical techniques have kind of come into play, we may be seeing kind of a shift away from them. And so this systematic review, which only had 5 studies included, but 2 met the inclusion criteria, but they talked about all 5, showed that there was really no difference in the rate of dislocations for individuals who use the restrictions and those that didn't. And all of these used an anterolateral surgical technique. And they actually showed that individuals who prescribed to the hip precautions also showed a decrease in quality of life, a decrease in movement, and a decrease in satisfaction post-surgery, because we were starting to instill that fear. If you've followed Dustin and I through some of our geriatrics course material, we talk a lot about trying to deal hope and not to instill fear. And when these precautions are necessary, don't get me wrong, we're not trying to be negligent in regards to what those precautions do, and if they're necessary, then absolutely we want to kind of err on the side of caution. But in this case, it seems that the use of these precautions actually created more of an immobility, more of a sedentary behavior that actually could have retracted from some of the success of surgery post-op. And so I can post this study. It was done in 2015. The interesting part about this is that one of the studies that they were included was in 2002. So we have some of these studies that have been showing that these hip precautions may not be necessary. And these studies are almost 20 years old. And so this got me thinking about some of the hip precautions. And in Kingston, where I'm from, it really does depend on the surgeon. So I know a lot of you are thinking, well, even if the studies are saying this, my orthopods are not going to be down with this. They're going to make sure that those hip precautions are in place. And absolutely, that is where that collaboration, that education on the side of being in a multidisciplinary team is sometimes going to dictate what we are able to do. But I am starting to see, especially with surgeons who are not actually slicing through the lateral hip, but are actually trying to retract the muscle without cutting through it and apply a prosthesis there, they're actually nixing the precautions. And I'm having individuals come into rehab relatively early being told that they have no restrictions. And so it's been an interesting shift in the last probably 3 to 5 years where we are starting to see surgeons who are taking into account some of that literature and playing around with when they're going to use the precautions, when they're not, based on their surgical technique. And I think that that's a really important consideration. Now, is there a case where these hip precautions might actually be necessary? And that probably goes into risk profiling. And so if we have individuals who are at very high risk for dislocations, we may want to be more conservative with their care, and therefore being able to identify individuals at high risk is going to be a really important part of our management. And so some of the risk factors, the 2 biggest ones being a previous dislocation, i.e. if this is a revision because of a dislocation, we're going to have to be more conservative and more slow in our progressions of care because that risk of dislodging or dislocating of the prosthesis is going to be higher. The other one is abductor deficiency, i.e. lack of strength in the abductors of the hip. So some sort of manual muscle testing or some sort of evaluation of the strength of the hip pre and post-op is going to be really important, because individuals who are more on the sarcopenic side of the spectrum in regards to clinical geriatric syndromes are going to be the ones who are at increased risk for dislocation. And so what we know is that the risk of dislocation is relatively low. Probably about 2% of hip replacements result in dislocation, but that could increase up to 28% for individuals who are going through a revision. And so identifying where people are along that spectrum and talking with your surgeon, looking at some of this literature and potentially giving some education or lunch and learns or something to your multidisciplinary team, discussing some of these precautions and are they really necessary, and are they holding our clients back because they're afraid? Because you can't sit in your car because my hip is currently flexed past 90. I can't get into and out of the car very easily because I have to scoop my butt in and then turn around. Even sometimes driving, you're getting into that internal and external rotation of the hip that is going to be contraindicated for the first 6 weeks. And so there's a lot of things that are restricted that if these precautions aren't necessary, may not be a necessary restriction on that person's life. So that is it for today. I hope you guys found that interesting. I've been kind of geeking out on this literature because I think it's really, really fascinating. And we've seen a couple of these, precautions or recommendations based on theory come and go. And it's interesting to see that the first implementation of these precautions were because of the way that the prosthesis was laid in, rather than somebody doing a study on what precautions were necessary based on rates of dislocation. So super interesting where we go with the research on this. If you're interested in geeking out on this, the study was by Barnsley and colleagues in 2015 in geriatric orthopedic surgery and rehabilitation. So if you guys want to check out that study, I'm pretty sure it's an open access article, so you'll have access to that, which is great. If you guys are interested in learning more about geriatric PT, we are currently in the middle of an online cohort, but our next cohort starts on the 9th of June. So if you haven't jumped on to the MMOA online course yet and you are kind of humming and hawing, now is the time to do it. It's going to be super, super fun. Can't wait for some of the discussion. We're having a great time with the cohort now. And if you're anywhere near Asheville, North Carolina in June, end of June, the 22nd, it'll be the first time I'm doing one of these live courses when I'm not pregnant. So that's going to be exciting. And we will see you there. All right, guys. See you next week. Bye.
Thank you for listening to the weekly Jerry on Ice segment of the Geros Health Podcast. If you found this episode helpful, you should go to geroshealth.com to check out our course offerings that will make it easy for you to better serve older adults. Once again, that's GEROS health.com and click on the courses tab. Thanks for listening.